I think when I got the title Sexual Health Counselling, I said, yes, I'll do the talk, but then I was thinking, do I really do this? But when I looked at my practice, it's something that I do on a regular basis, and I really don't appreciate the fact that I do it. So here are my disclosures. So I thought I just wanted to do, I think we talked in the last session a little bit about what sexual health is, but the World Health Organization said it's not merely an absence of disease, dysfunction, or infirmity. Sexual health requires a positive and respectful approach to sexuality and sexual relationships, as well as the possibility of having pleasurable, safe sexual experiences free of coercion, discrimination, and violence, which I think sort of sums up everything that I'd want to see. So when I was looking at putting the presentation together, I drew from 3 documents, and I thought it was quite interesting looking at the EACS guidance, the British HIV Association guidance, and then also a document that the nurses working in HIV put together, which drew together on both pieces of guidance. So what do EACS say? Well, I'm from the UK, and I think people from the UK are, if we're stereotyped anything, it's about our prudishness around sex and not wanting to talk about sex. So EACS said that you should take a sexual history, should be taken at diagnosis and every 6 to 12 months. And most of their guidance looked at sexual dysfunction and recommended psychosexual counselling around desire, arousal, orgasm, and pain. And the British HIV Association was quite different. So they looked at good sexual health being part of good overall health. And they looked at the impact of living with HIV as a potentially stigmatizing sexually transmitted infection should not be underestimated. But they didn't mention anything about desire or arousal or orgasm. People living with HIV and their partners require access to appropriate culturally sensitive and effective information and support around sexual behavior and minimizing transmission risks. And what do we need to know as practitioners? Well, we should have knowledge and expertise and be able to sensitively discuss sex and sexuality, safer sex practices, HIV transmission risk in context of effective therapy, HIV disclosure, and fear of criminalization. So about 3 years ago, the Nurses HIV Association put together a piece of work looking at what an annual health review should involve, and one of our standards is looking at sexual health. So standard 4 out of 9 standards is sexual and reproductive health and psychosexual well-being, and what we said is that all people living with HIV should be regularly screened, that all people should be supported in establishing and maintaining health and enjoyable sexual lives, and that people living with HIV should have access to safe, effective, and acceptable methods of contraception. So I think we brought together the best of the EACS and the BHIVA documentation. So when I was thinking about and talking about this with some colleagues, and I said, so sexual health counselling, what do you do? And they just talked about testing people for gonorrhea and chlamydia and syphilis and giving out condoms. They didn't really say about anything else. And I was quite shocked, I think, when some colleagues said, well, this is all we have time to do, really. But what are the issues? Well, there's a role of embarrassment, shame, and fear, and all of that's bound up in stigma. When we're looking after people living with HIV, we're dealing with people who maybe have just felt ashamed, embarrassed, may have been stigmatized because of their illness, may have had really bad experiences. One of my patients refuses to see his GP anymore because he said all he wants to talk about is anal sex. And he said, and I've not had anal sex in 20 years. It's about sharing HIV statuses with other people, and the whole of the issues around how do you tell someone that you're living with HIV. There's still a fear of criminalization, even in the age of you equals you, and I think some of that needs clarifying. We have an aging HIV population. There's a moral responsibility. So most research, if you look at sexual health counselling for people living with HIV, it looks at safer sex, and that's all it talks about. There's a lack of confidence in practitioners, nurses and doctors in talking to people open and honestly about sexual health. There are issues around changes of body image, particularly weight loss and weight gain, and I know Laura's going to be talking about weight gain tomorrow. But other issues such as neuropathy, skin rashes, changes to the way somebody looks. The condom talk. I think when we think about sexual health counselling for people with HIV, and I think it was brought out very nicely in the prep talks earlier, is it just about condoms? And is that all people feel quite happy talking about? And the lack of pleasure, it's very rarely researched. So if you look, when I was looking into this, trying to find something that looked at HIV, sexual health, and pleasure, very little came up. There has been some research. So Krepas and Marks in 2002 said that some HIV-positive people may need more intensive client-centered counselling from professionals to address personality, so issues such as sexual compulsiveness and impulsiveness, anger, blaming others for one's HIV infection, and dynamics underlying sexual risk behaviour. It wasn't a great piece of reading, this. It was really like putting all the negative issues into HIV and sexual health. And Shaun in 2018 said the prevalence of sexual dissatisfaction is high in both men and women living with HIV. It underscores the importance of a positive response instead of silence in clinical and social work encounters. So what they were saying is that nobody really wants to talk about it. And they suggested that staff should initiate a dialogue and offer counselling related to sexual satisfaction. HIV stigma has always been, when I look into sexual health, HIV stigma is always the big issue. And it can really draw upon issues around prejudice and very negative issues to sex and sexuality. It might even be related to attitudes about the appropriate amount of sex and the number of sexual partners. And again, I think the last speaker was saying, what is promiscuity? How many partners do you have to be promiscuous? And perhaps this in turn invokes sort of very gendered prejudice in people. And patients may delay their presentation because of embarrassment, fear of stigmatization, and ignorance regarding the seriousness of their symptoms. This is in a piece of work looking at damage to particularly MSM who have damage due to accidents around using sex toys and fisting, and the embarrassment that they feel in not coming forward, and so sitting back and waiting for things really to deteriorate. And there's a really nice piece of work looking at the role of shame in HIV. And I think for years we've been aware that some people just don't want to talk about their HIV status, find it very difficult, but shame can prevent an individual from disclosing all the relevant facts about their sexual history. It can serve as a barrier to engaging and being retained in care. It can prevent individuals from presenting at clinics for STI and HIV testing. So somebody who I look after, who's quite sexually active, he said, I can't go to the clinic, I think I've got gonorrhea again, I just can't go back again. And he just feels too embarrassed to go in. So he then ends up going to different clinics around London using different names. It can prevent an individual from disclosing their HIV or STI status to new sexual partners. And shame makes people want to hide and withdraw from the world and others. It therefore makes the task of living with HIV a far more negative experience than it should be or needs to be. And that was a piece of research from 2017. So, we're going to talk about sex. So why isn't it discussed? Well, when I was asking, so I asked some of my patients if they felt that sexual health or sex is discussed in clinic, and they said, well, I don't talk about it because I don't think it's important. So the fact that they may have erectile dysfunction, the fact that they don't have pleasurable sex, the fact that they may have pain, they just don't think on the big scale of things is important. And I think they cited that the doctor that they see didn't seem to be particularly bothered about certain things, or maybe focused on other issues like CD4 viral load, or maybe looked at other issues to do with their annual health review, so they'd look at their cardiac or their renal or their bone issues rather than talking about sexual health issues. So is it an issue for us as people working with people living with HIV that we need to make sexual health more important? There's an assumption that the person with HIV isn't having sex. My eldest patient is 86, and I had a big discussion about 2 weeks ago with him about sex and the fact that he was still having sex, and he found that he was having pain, and he thought his foreskin was going to seal up completely because it was retracted. And so I think we need to be aware that people will still have sex, they may not have sex, they may not want to talk about sex, but it's not just, a randy 18-year-old or a horny 30-year-old. It's somebody in their 70s and 80s. I thought this was interesting. The presence of a third party in appointments, so either a partner, an interpreter, a child, a junior doctor, 7 doctors sitting around a hospital bed. So I think it's important to think that if somebody's got something that they want to discuss, that they have the opportunity to say, can it just be between you and I? Could I ask that person to leave the room? Person living with HIV doesn't want to discuss and doesn't want to initiate discussion. And when I talk to colleagues, I've said, why do you talk about sex? And said, we'll only talk about it if it's brought up. So it's never raised as an issue. And it'll only be raised as an issue if somebody comes in with an STI. Familiarity. So they didn't talk about sex previously, so it never gets raised again. So you see the same person at each appointment, you have the same conversations, you may talk about your holidays or what you're watching on Netflix, but you don't necessarily talk about things that may be important or may be on somebody's mind. Too embarrassed, and this really cuts both ways. So it's the embarrassment of the healthcare worker, it's the embarrassment of the person talking about it. I've had patients who said, oh, well, if it was a male doctor, maybe I could talk about it. If it was a gay doctor, I could talk about it. If it was a gay nurse, I'd be more open. And not enough time. And I think this has been cited as a big issue. And I think it is a reality, unfortunately, that there may not be enough time in clinic. So I asked the people that I work with, chance would be a fine thing. I'd love to have sex. Find me someone to have sex with, I think is what they've said. I've not had sex in years. So when I was talking to one particular person, they said, when I was first diagnosed, I didn't want to have sex ever again, and then I felt better, and that by the time I felt better, I'd grown older, and nobody wanted to have sex with me. I don't want to have sex since becoming positive. I can't get an erection, and if I do, I can't come. And again, this is a guy who had been positive for 7 years and hadn't had sex in 7 years, and said that he felt aroused at times, but he thought there was something physically wrong with him. And with him, it just took a quick referral to the erectile dysfunction clinic, and we got him sorted. And then I had one guy who I've known for 6 years, and I don't think when I first met him was a crystal meth user and was compulsively having sex with strangers for years, and then was sectioned, and then his body image he felt wasn't great. And maybe about 3 months ago, I've noticed in his apartment that there was maybe like a bottle of lube, a bottle of poppers, maybe a few condom wrappers lying around. And I'd sort of asked him if he was having sex, and he said no. And then I went in one day, and he said with a big beaming smile, "I've got syphilis." And I said, "Oh, you've had sex then?" He said, "I've had a threesome." So it happens. I'm aware that I only see, on the whole, men, so I wanted to look at women. And one of my friends who's positive said, "Well, what about us?" So one study among women living with HIV found that the fear of stigma and discrimination resulted in some self-imposing restrictions on expression of sexuality and sexual desire. And that HIV often limited the woman's ability to experience sexuality and intimacy. We used to run workshops for people living with HIV, and I know a lot of the women in that room were very frustrated about the fact that they were not able in their minds to have sex and were looking for other positive partners, but were very well aware that they were looking for positive partners in a room full of gay men. Being HIV positive is associated with a lower sexual function and a higher prevalence of sexual problems. Almost twice as many women living with HIV reported low sexual function, and 2/3 of the women with HIV reported at least one sexual problem in the previous year. So it's a huge issue for women. And this is a piece of research that was brought out this year. And postmenopausal status was associated with sexual dysfunction in women with HIV, and an association that was not observed in HIV-negative women. And I think there has been a lot of research looking at sexual health within menopause for women. So there's a lot of menopause stuff, but we're not really looking at the needs before menopause. And Taylor and their research in 2017 highlighted the following characteristics of older women with HIV. Sexual pleasure increases with age, sexual freedom from the fear of pregnancy and traditional gender norms. And certainly we've seen groups of women who are postmenopausal and maybe newly widowed or newly divorced, who then became HIV positive because of new sexual freedom. Less pleasure due to partner and relationship characteristics, sexual risk behaviors, and ageist assumptions about their sex lives and serostatus. So in my experience, I think in my cohort that gay men feel more open to talk about sex to a gay nurse. Or maybe it's just me. Maybe they just feel that I'm quite chatty and they can say anything to me. And boy, do they say things to me or show me. I had one guy who said he was constipated and brought out a hose that he attached to his bath taps to douche with, and said that the doctor had given it to him. And I very kindly pointed out that it looked like it's something he'd bought from a shop and had really crudely hacked the top off with a knife. It's what are they not telling you? So I've had long conversations with people about their isolation and loneliness, and actually when you drill down to it, it is, for some of them, it's a lack of sexual intimacy. It's not being able to meet people. It's not feeling that they, particularly as older gay men, that they may have lost their looks. That the society, the gay society, particularly in London, changes so quickly. So bars close down, clubs close down, people don't know where to go, what to do. They're maybe not up to date with technology, so they don't have apps on their phone. You need to be honest about boundaries and what are you willing to discuss and what are your limits. And there are several times that I've had to say to people, I'm not, particularly because I visit people in their homes, so I feel very vulnerable if somebody says, well, I've got this rash on my penis, can I just show you? And it's like, no, not in your home. I'll refer you to the clinic, go to the clinic and see somebody in the clinic. It's vigilance when visiting somebody, so it's about recognizing what's around. I saw a gentleman yesterday, actually, and he just, on the corner of his coffee table, had one swab on the top of a needle. And he's never injected in his life before, and I just sort of started a conversation, and he'd started taking crystal meth. But it may not be just that. It's about noticing things like, so people will have like magazines hanging around, lube, condom poppers, medication, sort of Viagra. There may also be strange people in people's flats. So I've had conversations with people when I know there's been somebody else sitting in the room next door. I met a lady and she sold sex, and she had a gentleman sitting in the room with us, and she said, "Oh, don't worry, he's deaf. He doesn't understand what you're saying." And I asked if he could lip read, and he said yes, he could. So we had a whole conversation going, so your tablets are okay, you're taking your pills, without saying anything around HIV. And to recognize that everyone has sexual needs and wants to discuss it from ages 18 to 88. And I think it's something that I try not to shy away from now. So it's maybe something that I try and keep at the forefront of my mind, rather than talking about the stuff that I'm supposed to be talking around, like adherence. So what can we do? So think about whether or not U equals U has been discussed. I found that the whole U equals U campaign has been quite liberating, because it means that I can now, when I go and see somebody, talk about passing the virus on or not passing the virus on, and then having more open conversations about somebody's sex life. Be sensitive and non-judgmental, and think about body language. I know that when somebody says something to me that I find slightly off-putting, my face will say what I'm thinking. So I've got to be really aware that I'm not grimacing or looking shocked, and that I'm not sitting like this or looking really awkward. Initiate the conversation, and I find I've really got to get over the embarrassment. So sometimes I'll think, oh, I think, okay, well, I think they're having sex, and I know that they're not, and I know that they're detectable, so I need to have this conversation. I can't just walk away from this situation. And if you can't refer to someone who can, and don't ignore the need to talk about sex. Think about the environment you're in. So I visit people in their homes, and that's fine unless somebody's hanging around. But also, if you're on a hospital ward, we all know. In fact, I was sitting in a meeting the other day, and two people were talking about sex, and the whole room quietened down because somebody heard the word sex mentioned. And it's the same in a hospital bed. If you start talking about things, people will listen in. Make time or refer someone who has the time. And I'm a nurse. From my experience, it's usually going to be the nurse. The doctor will say, well, I've not got time to talk about it now, but go and see the nurse outside. And don't focus on what's wrong. Talk about what's right and try and problem solve. So it's not all negative, and think about the positives. And you've got to be trying to be creative. Sometimes I sat there thinking, I don't know what to say in this situation, but I'll find something. Unless it's illegal. Talk about it. And I've had people who have said that they have sexual desires that morally I find repugnant, and legally and not legal, and I've had to shut down the conversation. And when we put together the annual health review, we just wanted to look at just a few examples of questions that you could ask. And it is just about being really open. So are you having sex? If you're having sex, is the sex that you're having consensual? Is it a good relationship? Are you having pleasurable sex? How easy do you find it to talk about HIV with new sexual partners? Do you understand U equals U? When was the last time you had sex without drugs? And obviously, if you know somebody's taking something, it's just about naming it. So when was the last time you had sober sex, or when you had sex without meth? Do you have concerns about the kind of sex that you're having when you're taking drugs? And again, I met a guy yesterday, and he was having sex with somebody, and he just wasn't finding it pleasurable. And so we had to have a conversation about that. So in conclusion, I think this sums up nicely the last part. The ultimate goal should be to maximize an individual's possibility and recognizing him or herself as a sexual human being who has the right to sexual well-being. And I think as people working within HIV, this is our role as well. So it should be something that's discussed alongside physical and mental health. And thank you, there's references of that.